cartilage, you know, there's this theory of interlocked stress theory, which we'll talk about. If you make incisions, not just in the perichondrium, but in the cartilage, the quadrangular cartilage itself, you can really break this interlocked stress that can change the shape of cartilage as the cartilage grows. So based on that, should you postpone till after puberty? You know? Is there any psychosocial issues that are playing in the adolescence? And as you know, there's a lot of that. And then there's also conflicting studies. You can see some studies that show it doesn't make too much of a difference, and some that do. But I caution you in looking at that and really look at the ones that have an extreme follow-up till past puberty, till 21 years of age. Don't look at the ones that we look at, you know, when you're doing cleft lip rhinoplasty, and then look at 15 or 16. You got to look to there in the 21s and 22s. So, and then we're comparing animal research, which a lot of these growth center research has been done as compared to midfacial growth, and compare that to clinical human studies. But if you look just at the septal cartilage alone, you know, it continues to grow to age 25. So what about this interlocked stress system? You know, this is for Jack. I know Jack likes this stuff. Okay. So, you know, the key to that is really how the cartilage. Now we're not talking about the perichondrium. We're just talking about the cartilage. The cartilage is not homogeneous. The hyaline cartilage of the septum is not homogeneous. Within it, there's different strains on the outside of it, the peripheral versus the central part. And if you break that down, and more of the strength is on the peripheral, if you really cut that either by trauma or by doing a septoplasty or by trying to carve it, as we do when we have a concavity, you're breaking that down. Now you say, so what? That's how I straighten it. Well, you got to think in an adolescence, that may be at the time of surgery, and you can straighten that, but you have to secure that straightening because later on it's going to continue to grow, like I said before, a quadrangular cartilage to your 20s. So those forces that are broken, that scarring that you've created can recur. You can't predict the direction of that growth after that. So again, optimal timing. So what do I, and these are my opinions and my opinions only, what do I have distinct indications for operating relatively early? Now you can argue what does early mean. So certainly acute nasal trauma, a septal abscess, any type of malignancy, especially near the skull base, the cribriform malignancies, a severe septal deviation that's called a severe obstruction, germoid cyst, or any midline congenital tumor, and progressive distortions like we do, these surgeons in the room here, like cleft lip, nasal deformities, congenital midface deformities, vascular malformations as shown here on the right. But more important is really those that affect the patient. This is where we have to play the psychologist with severe self-esteem issues. Now, self-esteem is really locked in between 5 and 10 years of age. And it's hard to really change that. You can, but the majority of our self-esteem is locked in relatively early before puberty. So if you can change any of that nature, that's a force to make you think to operate early rather than later. So you got these conflicting things that are going on: growth, self-esteem, psychology, and again, changes that you can do surgically and what you can do surgically and how does that affect growth. There's also two significant growth spurts you have to consider, and they're different in girls than they are in boys, okay? You got the first, which are certainly in the first postnatal years, but then in puberty, that's when it happens the fastest, and it's the most accelerated. And that can be anywhere from 8 to 16 years of age. Now in a girl, it's usually 8 to 14 years, so you can probably after 14 or 15, very safely without any consideration of growth, go ahead and operate on a girl. On an adolescent boy, it's a little bit later until after 16. So those are sort of sure things that you can sort of lock your thoughts on. 14 for girls, 16 for boys, without worrying about the controversy behind scarring. And also, it's the type of surgery you do. There's rhinoplasty, then there's septal rhinoplasty, then there's aggressive septal rhinoplasty, then there's septal rhinoplasty where you deal with the intermaxillary crest and vomer and perpendicular plate ethmoid. So again, as we all know, a cleft lip and a palate is not a cleft lip and a palate. They're all very particular. And the same thing goes for rhinoplasty. Any rhinoplasty, depending on how aggressive you are and what technique you do when you operate. So some considerations that I have seen and have read is really the surgical indications that I've seen most common is really aesthetic rhinoplasty, that's around 25%. And then the second, which is a close follow-up, 16% is cleft lip nasal rhinoplasties. Surgical approach, I think most people in this room do open 80 to 90% of the time. Specific techniques, because you're either going to borrow some cartilage or have some septal deviation correction, 70% will have some type of concomitant septoplasty. And then about half of them, you'll use some type of graft, either for an intracolumnar strut or Ehlers strut or whatever to correct some deformity, especially in the cleft lip rhinoplasty. Again, the optimal timing is non-specific based on our arguments and discussion before, and that is relative to the extent of the operative and the aggressiveness of the operative intervention. So some of my guidelines that I have learned over the years, take it or leave it, is as I get older, as I said before, I'm conservative. I feel that the elevation of the mucopericardium doesn't affect or interfere with growth at all. And I would recommend that despite that, they use septal mattress sutures at the end of that to secure that and lock that in. I think scoring an incision in the cartilage, as I said before, based on the interlock theory, does not achieve predictable results, especially in growing cartilage. And separation of the upper septal cartilage and perpendicular plate of the ethmoid should be avoided, especially in those patients under 12. I think central cartilage grafts do not inhibit with growth, so if you want to take from the center part of the quadrangular cartilage and use that, what most people do, and not interfere with the vomer early on, and use it for structural reconstruction in addition to aesthetic reconstruction, I think that doesn't interfere with growth. I think if you're aggressive though, and you're aggressive both inferior and posterior onto those growth centers, especially deep in the sphenodorsal areas, that can lead to nasal-dorsal outgrowth deficiency, and certainly in the vomer area, as long as you stay superficial, you can take a little bit of the vomer, especially if it's obstruction, you need to, but I try to stay away from that. Anterior to that, especially in the intermaxillary crest and nasal spine, I think I commonly shade that. I think that's a lot of the obstruction and the subluxation of the quadrangular cartilage off of that causes the obstruction. So I commonly shade that, and I have not seen that, at least in my cases, with any severe or changes in growth over 20 years. I think leftover septal cartilage is very precious. What you don't use, you should put it back. If it's not straight, you should crush it, straighten it, and put it back. Resection of bony deviations, especially what I do quite common, the intermaxillary crest, and partial superior, superficial resection of the vomer, if needed, has not, in my opinion, led to any growth disturbances. Again, the dorsal hump resection is very important too, because if you remember that upper lateral cartilage is doing more superior than what you think as compared to an adult. And the younger that patient is, the more that upper lateral cartilage is doing more superior. So if you separate that by doing a large nasal-dorsal hump resection with, say, a 10 millimeter osteotome or some other oscillating saw, you got to be very careful, because then you're producing dorsal changes that you'll have to correct either by a spreader graft or some other type of structural support. And then sometimes a lot, I will onlay something to camouflage that, knowing that it may be needed as the patient grows on. I think the frontal process of the maxillary osteotomies, I've never seen that disturbing any mid-phase growth, and there's no really growth centers in that region too from the frontal process of the maxilla. I commonly do a step-up. I used to do a Gullwing. I do step-off incisions in the mid-columnar waist. Again, the scars are excellent, and nobody ever complained about it. And again, I've never had any problems with growth on that. Cartilage grafts, you know, I tend to use more and more cartilage graft as I go on. I tend to realize that some of the results from those cartilage grafts, along with the sutures that I use, have sometimes unpredictable results. And I caution my family, the parents, and the patient that I give myself a 5% out. If you look at the literature, sometimes the literature will give themselves a 10 or 14% out of minor revisions down the road. So I usually say 5%. And that's because as the child continues to grow, there may be revisional surgeries needed to correct some minor changes, especially in the tip and the lateral crura, and in addition to the upper lateral cartilage on the side that's deformed. Larger disturbances of the cartilaginous dorsal hump should be delayed due to the use of spreader grafts. So if you're going to not use spreader grafts, be careful, because you may be caught with your pants down and not knowing what to do once you take down the hump down too much. And if you do, and you need a camouflage, we'll talk a little bit about it near the end. I use either a Turkish Delight or what we call the American Blend. I'll explain to that to you a bit this later. Conservative ailer-based wedge resections, I always think the wedge resection, the old weir incisions and resections, to me, I can spot that a mile away. And I think that is poor technique. I like to do internal wedge incisions so you don't see that scar. And you commonly remember, especially those that do cleft lip nasal surgery, cleft lip and palate, that those that come across at the area of the nasal base, that is a virgin area. That nice curve of the alar cheek junction, you cannot mimic once that's destroyed. I've tried, and I still don't have the technique or the talent to do that as of yet. So to me, that area is very, very particular. And so when I do wedge resections, I try to do it by wedging the inside of the nose and using PDF or some type of long-acting suture to really form that into that nasolalar junction that I want. The alar base, piriform maxillary augmentation, again, you do that with your bone grafts, rib cartilage grafts, and even porous polyethylene med-port. Don't see any restrictions on that. Tip suturing techniques. When that came out, I thought that was a big boom to rhinoplasty, and I really studied that by Tebbets. And I really credit him really to popularizing that more than anybody. And if you really get his book, I go back to that again and again. All those different types of mattress, and there's many different suture techniques, not just the simple mattress techniques. And you have to play with it over a period of time. So the more noses you do with that, you'll find out it's not just putting the stitch in, it's the tension that you address at the time. And I can tell you, and the residents will show, and that I'll take that down 3 or 4 or 5 or 6 times, because I just don't like it. Because it's more than the technique, it's the tension placed on that technique. Shield grafts and tip grafts, there's no growth restrictions, though they do ossify. We did a study years ago, just a simple pilot thing where we went back, and this is when I was in ENT, and we did some x-rays of those people who had open rhinoplasties with shield grafts. And about, I would say a third of them would ossify. And you can feel it, and some of these patients will complain about it after 5 or 6 years. They'll feel a crunch or anything when they manipulate the tip. So they do change. They probably get some type of ectopic calcification, at least some of them. And then autogenous grafts, always used. And if you don't want to go with the septum, or because of previous surgery trauma, septum's not there, then you have 2 other alternatives, ear or rib, okay? Now ear, I like ear as far as a forming, but ear really has, since it's elastic cartilage, has very poor structure. So usually I go to the rib at that time, which in a girl or a woman is very nice because you can hide the incision in the inframammary fold. For a boy, you have to think about it twice. But if I'm looking sort of as a spreader graft just to spread things apart, or as a form to lay something on without structure, then I'll go to the ear, and I'll do an anterior incision. And I thank Bruce Bauer for pointing it out years and years ago, rather than a posterior incision. It's easier to obtain, and you have to be very careful, because besides it being elastic cartilage, it's kind of brittle too. So the dissections of that is very important, and the technique that you deliver it is very important. But if I need any structure at all, I'll go straight to the ribs. The other thing is infections with PDF plate. Now I know Arun used PDF plates a couple of times. I've used it, and I got a couple of infections with it, and I've actually shied away from it. I don't do it anymore. If I need something for the septum, like a septal perforation, I'll use ear cartilage and maybe even Aladerm to structure that. But I've gotten away from using PDF plates, either as structure on top of the nose or for perforation repair. I've taken out silicone and med-port in the past, especially on the dorsum. Don't use it at all. And I've taken out permanent sutures. I used to use nylon, but I don't use nylon anymore. Nylon is cutting. It's like fishing line. And then I've had a recent patient, about 3 or 4 years ago, that I reoperated on again and again and again, taking out nylon suture because it kept on getting infected. So I've switched totally over to PDF, both 4.0 and 5.0, and that's sort of my suture du jour of choice. Cephalometric analysis, if you have the capability of doing this, I always recommend it. It's always nice. It's worthless as a guarantee to the patient. I use it just as a guideline and sort of a map, an architectural map, but it's worthless for everything else. But I still like to use it. It gives me sort of an idea and a reminder throughout the case to go back to the psychometric analysis to see what changes are needed, what changes I can do, and what changes I can't do, what techniques I can do. And I actually write sometimes on that, showing what techniques I'm going to do on the psychometric analysis, and really sit down with the parents and the patient and explain that. But I always say at the end, and I write down no guarantees. This is a picture and a drawing, and there's absolutely no guarantee, but this is my guide. The psychology of adolescence. All of you that have had children know about this. You know, it's a time where there's a lot of, I would say, disruption in how the patient will feel about themselves and how they feel others look at them. And so because of that, you know, I think the body image and their independence, their sexuality, and more important, sometimes even the peer relationship, being teased and bullied, sometimes can have a big play on operating earlier rather than late. You know, this body dysmorphia syndrome, as Costangian is a great proponent of that, and I've read a lot of his papers. You know, a lot of those patients happen mostly in girls, young girls, or in teenage girls up to the 20s. So you have to be careful of that and always have that in the back of your mind. And as Salvador Dali always said, you know, have no fear of perfection, you'll never reach it. And I certainly think that's true in myoplasty, especially talking to the patient. Just a few techniques that we've developed over the years. This is the Fulcrum spreader graft. It's not just a spreader graft, it's using the spreader graft as a pivot point, like the fulcrum of a teeter-totter, and placing the upper lateral cardiac on top of that, and using, again, a tension type suture, what I call the suture of Parks from an old paper in the 60s, which is a vertical mattress type of suture on top of that. And that's been very, very important to me. We've done some studies utilizing acoustic rhinometry studies before and after with cadavers and in patients. In the cadavers, we've shown that it increases the square area, especially at the internal valve, greater than any of these other techniques, including Sheen spreader graft. And using negative pressure to induce an inspiration negative pressure, we also show it really provides the best resistance to collapse as compared to the other two. Nasal dorsal augmentation, you know, the ideal graft is something that's predictable. I used to use rib grafts a lot for that, but it would distort over a period of time. I didn't like that. And then I saw, we had actually a visiting professor, Dr. Zins, brought in Dr. Earl, and he turned me on into the Turkish Delight. And I didn't know what a Turkish Delight was for a long time. But it's not baklava, you know. It's basically this candy that has, it's like gelatin candy that has stuff in it. But I thought, well, if he's wrapping it up, it's going to be like baklava. But it's not. And then Roland Daniels came into play. And he really did the same thing, but he used deep temporalis fascia. And I thought, well, that makes sense. It's autogenous. It's either septal or ear cartilage, elastic cartilage. He's dicing it and rolling it up, putting it in there. And I thought, you know, putting a scar, and those of you that do craniofacial surgery, and you know, what is the greatest width of scar that you have after surgery in a grown kid? It's in the temporal area. And I've had problems with healing granulomas in that area, especially through puberty where you have hormonal changes. So I said, no, I'm not going to do that. So what we came up with is using diced cartilage that we can easily manipulate, and we thought using Alloderm that we can perforate and then dicing up the crushed cartilage. The best would be Hyman cartilage, obviously, and then rolling it up. And so we affectionately call this the American Delight. So we use it quite a bit, you know. It's expensive in the sense that you have to add that to the case. But especially in congenital deformities like this Kidney-Binder syndrome, you know, you can see the projection that we got with that in addition to an intercontinental strut graft. Here's somebody with an ectodermal dysplasia. We didn't get much out of it, but again, you've got some prominence more, especially in the nasal dorsal area. This is from severe trauma. Again, we used a lot of grafts and ran out of grafts on her nasal dorsum. We used rib grafts on her. But in addition to that, I did this American Delight, borrowed from the Turkish Delight, and try to repair that. Again, give her more dorsum. And this is a classic cleft lip rhinoplasty, where, again, the nose is what he wanted done, and how to correct that. I think a lot of that is, again, tensions, and I commonly release sometimes the whole lateral curl. I'll release it as a mucoperitoneal flap and then restructure it with either strut grafts. Either put composite grafts, ear composite grafts to line that. But the key to that is really the stent that you use to stent it for a long period of time. And I think we get a fairly good results. And in addition to layering on top if you need to with some type of American Delight. This is a girl, obviously after a Fort 3 distraction, again, using a similar augmented device on top of her nasal dorsum in addition to intercolumnar struts and a septoplasty. Thank you.
So questions from the audience? While we're waiting for that, maybe I could ask Andrea a question. Andrea, I know you had some experience with the Curi external expansion device, the Brava device. Do you see any place for that in that patient population to enhance your graft tape?
It would be great if we had it available. It's hard to get the device right now. I think patients sometimes can get it on eBay. Somebody corrects me if it's different, but I don't use it for that reason. It's expensive for patients to purchase that. You need the patient to actually be committed to use it. Now it's just for 2 weeks. That's what he recommends. But still, they have to keep that on for 2 weeks. The cup size doesn't fit everybody. I don't use in my population. I think if you don't like overgraft, you can always come back later and do one more round. But we don't have it available. I don't know if anybody else does.
So what would you say your average number of revisions is